over the course of many years now that we've used it, and we've seen good results where we have been able to identify elevations in cell-free DNA before the changes in creatinine happen.
Oh, I see.
So that helps us guide or pick up these rejection events earlier compared to just waiting on the creatinine.
Hi, I'm Dr. Phil Gauthier, a transplant nephrologist and Senior Medical Director at Natera. For today's episode in our series, we're joined by Dr. Akshay Athreya, a transplant nephrologist from Virginia Commonwealth University. Dr. Athreya will discuss with us how he uses Prospera for the surveillance of his kidney-pancreas transplant recipients. He will also describe the correlation between Prospera and findings on molecular microscope. And finally, he will describe how he uses Prospera to coordinate care with the community nephrologists in his area. I hope you enjoy this episode. Good morning.
Morning.
How are you?
I'm good, thank you.
Thanks so much for being here.
Yeah.
And I understand you're a transplant nephrologist
Yes, I am.
at VCU,
Yes.
and you're going to talk to us today about Prospera.
Yes.
Great. So let me start by asking you, how did you first find out about Prospera?
So our group has done a lot of work on cell-free DNA,
Okay.
and mainly in kidney transplant.
I see.
We've seen that we need a non-invasive marker where biopsy is not always practical, it's invasive. Sometimes patients are on anticoagulation, which makes it difficult to plan for a biopsy and get it done. So having that non-invasive kind of biomarker has helped guide therapy for us over the course of many years now that we've used it, and we've seen good results where we have been able to identify elevations in cell-free DNA before the changes in creatinine happen.
Oh, I see.
So that helps us guide or pick up these rejection events earlier compared to just waiting on the creatinine. Our institution does not do protocol biopsies. I know some institutions do that.
Yep.
Like for the reasons that I just said, right? So invasive, time-consuming. Sometimes people are on anticoagulation, so we don't find that practical to do so many biopsies. So having that cell-free DNA as a biomarker helps guide us. In some cases, we end up doing a biopsy, knowing that the cell-free DNA is still high, and our yield for that is much higher, obviously. So we've used it in that way, and Prospera is the same, right? So we've used these tests to determine what our future, like how high we think rejection is a possibility. In high-risk patients, we've used it to kind of guide to say that, okay, now the cell-free DNA is low, which is good, that you don't need a biopsy and you don't need to subject the patient to any invasive procedures, and you can be rest assured that the allograft is doing well. So we've used it that way.
So it sounds like you're confident if the Prospera is negative that the patient does not need a biopsy. Is that true?
Yes. So most of the time we use that in that way because of its high negative predictive value, as you know. So if it's negative, and other clinical parameters like no DSA, all these non-invasive markers are negative, then we are pretty confident that there is nothing going on in the kidney, and that we can just observe and leave the patient on whatever immunosuppression they are on.
Okay. And do you use it at all for surveillance for clinically stable patients?
In higher risk patients, we have used it for surveillance. So when I say high risk, I mean people who have high PRAs or have had, say, DSAs in the past, or have had cross-match positive at the time of transplant, etc. So these patients, we've used cell-free DNA at different time points in kidney transplant patients. So like 3, 6, 12 months, something like that, to kind of, again, the same way. So if it's negative, we are happy that it's negative, and we know that there's less likelihood of anything going on in the kidney. if it comes back positive, that helps too, because it helps us pick up rejection events before the creatinine is high.
Right.
And how we've been doing it is, if it's high, we then go ahead and do the biopsy to kind of guide our therapy, right? So based on Banff criteria, whether the patient needs steroids versus thymo, or if it's AMR, then whatever treatment that protocol that we have after that.
So how does Prospera compare to the other biomarkers? You said it's better than creatinine, but what about some of the other ones?
Creatinine for sure, because it's much later that the creatinine goes up, right? Just comparing with DSA alone, also, I think we've picked up maybe around 50-60% of our cases where cell-free DNA comes back high, the DSA is negative. So again, and then if we go ahead and do a biopsy, we've actually published some work as well in this field. So if we do a biopsy, it correlates more with the cell-free DNA rather than just DSA or just creatinine alone. So that way, I think we've seen, and we've published data on this, that the cell-free DNA is better than just DSA alone, or just the creatinine alone, of course. Yeah.
Well, that's great. And how do the patients like Prospera?
Yeah, so they appreciate it being non-invasive, right? It's a blood test, which means that they don't need to go through the whole process of being NPO.
Right.
Coming
no
to
one
the
likes
hospital.
being NPO.
Yeah, nobody likes being NPO. And it's a whole day thing, right? So even if biopsy is an outpatient procedure, you need to take the day off work. You need to come in the morning, get the biopsy done, stay for a few hours, make sure there's no bleeding, etc. And I think everyone appreciates that any invasive procedure has risks of its own.
Yep.
Especially, like I said, a lot of our patients are on anticoagulation, which makes it that much more challenging.
Right.
Sometimes we have to admit patients just to coordinate, with the anticoagulation, put them on a heparin drip, etc. So it's a long drawn affair, and if we can avoid that by doing non-invasive biomarkers, I think patients appreciate that a lot.
That's good to hear. So let's shift gears a little bit and talk about how you use Prospera for kidney-pancreas transplant recipients. So can you describe how you use it in that scenario?
Yeah, so we've seen the latest data about multi-organ transplants, and we're excited by that. Our program does simultaneous pancreas kidney transplants as well as other multi-organ transplants. So we think that we can extrapolate the same kind of pathway that we have for our kidney-only recipients and use it in the same way in the SPK patients as well. So we are excited to go ahead and do more. Like, we have high-risk SPK patients as well, just like I described, just kidney only.
Right.
So I think moving forward, we want to make a protocol where these high-risk patients are treated just like the kidney-only patients. So we want to do something similar. Right now, what we do is on an ad hoc basis, where we are suspicious of something going on, something unexplained like new onset DSA or rise in creatinine, etc. Then we do a Prospera test in an SPK patient to see if a biopsy is needed. So SPK is even more challenging because a pancreas biopsy is very difficult to do. So that gives that added advantage where, if you're not sure amylase lipase is up and the kidney function may be discordant with the pancreas, so a kidney biopsy isn't going to help probably.
Right.
So then we may use Prospera to guide our therapy about what's going on. I'm pretty excited about what we can do going forward with these patients.
So I'd like to talk a little bit, if you would, about molecular microscope. I understand that VCU uses molecular microscope quite a lot. So could you start by describing what molecular microscope is, and then perhaps discussing how it contrasts with what you see on Banff diagnosis?
So molecular microscope is a technique where we use a portion of the sample from the kidney biopsy and send it for examination. So we check which genes are being expressed in the tissue. and therefore predict whether there is any immune activity going on within the kidney tissue. What we've seen is that it using the molecular microscope adds on to what we know, and so combining it with, for example, cell-free DNA, DSA data, and the histology itself, what we've seen is that molecular microscope combined with these other markers enables us to catch these very early.
Right.
For example, especially TCMR, catch it very early and guide therapy even before the BANF histology is obvious enough for us to pick it up. So we've had multiple presentations, publications about how there is some discordance between molecular microscope and histology, where the molecular microscope has proven to be in future, like when you follow up, that's shown that the molecular microscope predicted what is going to happen in the future. So it picked it up early, especially in the case of T-cell mediated rejection.
Okay. And for T-cell mediated rejection, I believe there's some studies showing that in BANF, some of what's called T-cell mediated rejection turns out not to be rejection by molecular microscope. Can you talk about that a little more?
Yes. So early stages of T-cell mediated rejection that is picked up by BANF does not actually, it is not picked up by molecular microscope. So molecular microscope actually says that there is nothing going on or no genes being expressed, whereas a pathologist or the histology might show that there is early TCMR 1A, etc. So these patients are subjected to higher immune therapy, putting them at risk of rejection, of infections, etc. So therefore, we are able to distinguish between these early phases of rejection, which is picked up by histology, and say confidently with molecular microscope that this probably does not need any treatment.
And they don't need treatment. Yeah. And how does Prospera fit into that? I mean, does Prospera help with that decision as well?
Yes. So if Prospera is negative, that adds on to our confidence in saying that there is no immune activity going on, right? So what we do is we take all three together, cell-free DNA, histology, and molecular microscope, and combine and see which way it is going. So for example, if the Prospera and the molecular microscope both say that there's no rejection going on, or they're reassuring, then we are reassured that these early TCMRs that are picked up by histology actually may just suggest injury rather than any kind of immune event, and that they don't need therapy with immune suppression. So we've used that successfully at our institution.
Interesting. And do you find that Prospera correlates better to the molecular microscope findings or to the conventional findings for TCMR?
No, I think it correlates better with the molecular microscope findings that we've seen.
Interesting. Yeah. Okay. So I wonder if that's one of the reasons why they say that cell-free DNA is not as good for TCMR. Maybe it's the biopsies that aren't as good for TCMR, and the cell-free DNA is better, perhaps. Yeah.
Perhaps.
So, any other thoughts you want to share on your experience with Prospera?
I think it's exciting to use this, and I believe that for patients who are many years out from transplant, again, if there is any suspicion of any immune activity, it can be used even years out from transplant to see, or just reassure patients that there is nothing else going on, and that the graft health is pretty good. So
okay. So let's talk about that some more. So why do you think it's valuable in patients that are further out? Are they still at risk for rejection?
So yes, we've seen patients who are years out for different reasons. Maybe they had an infection episode where the immunosuppression was reduced for a while, or some other reason they had an admission in the hospital, missed a few doses here and there. So then again, we've seen that they are at then increased risk of rejection at different time points. Obviously, the risk is higher earlier from the transplant, but even a few years out, there may be a risk of rejection. So again, in that case, I think cell-free DNA Prospera is helpful in guiding therapy or guiding our next step, what it should be, right? So could it be that there is just some kind of drug reaction that's going on, not an immune event? So in that case, you're reassured by a negative
Right.
Prospera, or if the Prospera is high, then you say, okay, there might be something going on, and I need to act
Sure.
on it a little more carefully compared to when it's negative.
And do you continue to care for the transplant patients for the rest of their life, or do you coordinate with the non-transplant nephrologists in the community?
So most of our patients move back to their community nephrologists after about 1 year after transplant. Um, they follow with them as well as us for some time
I
after
see.
that. Um, so we still have not as close follow up, but
Mm-hmm.
we still have some contact with the community nephrologist. I think we are lucky wherein we have a group of community nephrologists who we interact with frequently
Great.
and share the mutual patient's care. So it's been beneficial where sometimes if they call us and say, they need help with this, and we say, okay, let's see what the cell-free DNA shows,
Mm-hmm.
right? So if they have an issue where they're not sure what's going on, creatinine is high maybe, or there's new DSA, for example, that they've picked up, then we think that instead of jumping to a biopsy, there may be a role for cell-free DNA, which if negative reassures us that probably this is not something that is immune that is going on.
So it sounds like Prospera is helpful in the coordination of care between you and your referring
Yeah, I
nephrologist.
would say that. So again, it avoids an unnecessary biopsy.
Mm-hmm.
It reassures patients and the community nephrologists alike that whatever they're dealing with, it's probably not a rejection episode,
Mm-hmm.
which is the biggest fear, right,
Right.
for the patient as well as the doctor who's taking care of the
Yeah.
patient.
So your community nephrologists are familiar with Prospera, and they feel comfortable using it, or do you direct it?
No, some of them. So because we've worked with them for so long,
Mm-hmm.
they kind of know what our next step is going to be, and they sometimes send us their patients saying, "Hey, Prospera came back high. Can you take care of this, or can you do a biopsy? We
I
don't
see.
have the resources to do biopsy, for example." So in that case, we also get patients back to us after they've had a high Prospera result. So our relationship with our community nephrologist is pretty close.
Mm-hmm.
We've had patients both ways, right? So we've had patients where Prospera came back negative, and we told them, no, hey, we are reassured that this is not something serious that's going on, or it came back high, and then we did a biopsy and then guided them through that initial phase of therapy, and then sent them back to the community nephrologist after that.
So what advice would you have for a community nephrologist that's watching this video on how to get started with Prospera testing?
So a couple of things to mention is, one is, I believe there is a way of getting this done at home as well. So if
Yes.
there is a patient who cannot make it to the clinic, or for whatever reason, logistical issues, etc. So there is a way for them to get this test done at home, which I
Mm-hmm.
think is beneficial in some cases. So it's a non-invasive blood test, right, which can be
Right.
done. Um, and if it's negative, that gives you reassurance that there is nothing going on immunologically, at least in the kidney. And you can reassure the patient, and you can be reassured yourself that the immunosuppression, etc., is not what is not does not need to be changed at that point. So I think it is a useful tool for community nephrologists. Again, doing a kidney transplant biopsy is not easy
Right.
for the patient and for the hospital or wherever you're working. So if you can avoid that and get good information just from a blood test, I think why not, right?
Yeah. So Dr. Athreya, you said you were creating a protocol going forward. Can you describe how that protocol is going to work?
Sure. So we already have a protocol for our kidney transplant patients,
I see.
especially the high-risk ones,
Mm-hmm.
where we do serial cell-free DNA to kind of make sure that they stay on track, and we do it like 3, 6, 12 months, etc.
Okay.
Making sure that these high-risk patients are not missed. So we don't pick up rejection later than what we are supposed to. Our center also uses telehealth quite frequently. So I think the fact that Prospera can now be done at home improves our ability to do these tests while offering telehealth services at the same time, right? So we are looking at creating a protocol for our high-risk pancreas kidney transplant patients as well, using the new data, which shows that Prospera is good for these patients as well. So we're looking to create a similar kind of protocol as our kidney patients to see if we can pick up episodes of rejection before that. So it would, I suspect that when we do telehealth, we would utilize the mobile phlebotomy service, where patients can get their blood tests at home, include a Prospera in that, and therefore it'll be convenient for the patient to get this done.
Right.
And that gives us some sense of direction about how the transplant is doing, if there's anything that we need to do, whether we need to bring the patient in for a biopsy or whatnot. If it's negative, then we're happy to continue doing telehealth and follow the patient that way.
Yeah. Okay. That sounds like a really interesting protocol.
Yeah.
You'll have to let us know how it works out.
Sure. We'll be in touch.
Thanks so much for joining us for this interesting conversation. I hope you enjoyed it as much as I did. Don't forget to subscribe to be notified about our next exciting episode. Thank you.